Good afternoon. I could relate to so much of what Taylor just talked about because of an experience I had myself. I've been a nursing home administrator. I currently work on the academic side. I oversee a long-term care administration program for college, but I am a licensed administrator. In 2007, I had a very serious car accident. 3 members of my family died, including my wife, and my son ended up being injured seriously as I was. And I became a resident of my own nursing home for 2.5 months as a skilled rehab resident. I entered non-weight bearing on 3 out of 4 limbs, extremely dependent on the staff who would care for me. My own staff, people I knew in a much different type of relationship, but now suddenly this is a very different relationship. Eventually, after I recovered, I was able to go home, had to put together a funeral, had to return to testify in a trial for the other driver who was sentenced to prison. Then I came back to work full-time, returning as administrator, now overseeing the people who had just taken care of me. To say this was life-changing and a change of perspective would be a tremendous understatement. There were a lot of things that changed for myself in the way I ran my nursing home. I had a lot of time to think, and I changed not just some things operationally, but also a lot of my own personal philosophy about caregiving in long-term care. That spans numerous topics around the care provision, but today I really want to focus on the care plan. Now, we all have care plans for our residents. But if the truth be told, primarily our care plan is to satisfy a regulatory requirement, am I right? And secondarily, it's actually talking about the care that we are providing to the resident. But I started to wonder about the care plan, my care plan, because I attended care planning meetings, but not once did I actually see the document. So I can't tell you what was on my care plan. I can probably guess pretty well, but I didn't actually see that document, so I don't know for certain what was on my care plan. Initially, when I came into the nursing home, as I mentioned, I was non-weight bearing. I was also on IV narcotics, so I wasn't really in a position to do a lot of participation in my own care planning and making decisions. But over time, that changed. I was able to wean off the medications, and I was able to take a more active role in discussing and planning my own care. But still, I didn't see the document. I'm not exactly sure what it said. There was one time as administrator before this accident occurred that I was called on to go talk with one of our residents who was being non-compliant with his care plan. I'm sure you have run into this before, that delicate kind of conversation. And I remember talking with this man and explaining, you're being non-compliant with the care plan, and his response, of course I'm being non-compliant. That's your care plan, not mine. Ouch. And as I thought about it, he was exactly right. That was our care plan, and we were asking him to be compliant with a document he had probably never seen. How fair is that to the resident? I also remember the day, as resident myself, when my dietary manager came into my room. Now, she is known as having a very strong personality, to put it mildly. A lovable, wonderful person, but a very strong personality. When she came into my room and told me that I was being non-compliant with my dietary care plan, I looked back at her and said, "Oh yeah? Well, you're overbearing and intrusive. You want to draw the line and start the battle? Let's go." What an insulting thing to say. And I'm sure she didn't really mean it that way or didn't realize how it came across. She was there with a purpose in mind, didn't really think about it. But now let's stop for a second. The nursing home is the resident's home, correct? It is also the workplace, and sometimes we have to kind of feel out that dichotomy. But would you walk into anybody else's home and start throwing insults at them? You probably would not be invited back a second time. That's just not polite. But when she came in and told me I was non-compliant, it was a workplace, not a home. And we're really trying to contribute to that home-like environment where our residents feel comfortable, but yet so much of the language we use And the practices we use are unintentionally reinforcing that this is an institution, not a home. When I returned as administrator, it was a few months after this experience with her, one of the first things I did was to banish the word non-compliant. I no longer wanted to see it in any resident charts. I didn't want it to even be discussed. That word was off limits. Because if you think about what the word non-compliant implies, as I've said, it's already, this is an insult. It's a very negative term. What it implies is, I'm the clinician, I'm the expert, I know what I'm doing. You are my subject, you will do as I say, or else I will label you non-compliant. And once that label is on, it sticks. And you cannot shake that. And I've known people who were labeled non-compliant, so no one took their concerns seriously, when in fact they had valid concerns. You've probably seen that as well. What an awful situation. We have the expert and the subject. Is this a partnership? And philosophically, ideally, don't we want a partnership? That we're all on the same page, we all trust one another, we're all working towards the same goal, trying to help the resident get well to the best of their ability. All of these wonderful, ideal things, but yet, by using the word non-compliant, we are establishing an adversarial relationship, not a partnership. So that's why I banished the word non-compliant. Furthermore, let's think about this a little more, where we're actually putting meat onto the philosophy of care provision and long-term care. A care plan, ideally, should be resident-directed, resident-centered, resident-driven. Would you agree with that? So, resident-centered means it is really all about the resident. It is not all about satisfying the regulatory requirement, although that is important, don't get me wrong, but it really is all about what is important to that resident. But if the nurse manager or the dietitian or the social worker, whomever, is drafting a care plan document in their office, not even in the same room with the resident, then how can it be resident-driven, resident-centered? It's all about what the resident needs. Well, that means you might actually have to ask that resident what they need, what they want. What a novel idea. In my case, you would think that it's pretty obvious. What I need is physical rehab, regaining strength, allowing bones and fractures to heal. I had a few surgeries. I was prone to decubitus ulcers, and all the wonderful things. If you are weight-bearing on one limb, all of that physical rehab, you would think that would be the most important thing in the care plan. However, my son had recently been adopted. He's 13 years old. My wife and I were foster parents waiting to adopt him. We had taken this trip where we had the accident to introduce him to some of our family. So I have a son with fetal alcohol syndrome who also doesn't have a lot of attachment, who has a lot of fear and anxiety, and well-placed fear and anxiety. His birth family, we were told, never let them know who you are, where you are, anything about you. Try to keep a low profile. Because the birth father is a violent alcoholic, he's in and out of jail, and he only lives 30 miles from you. The day after our accident, our pictures, everything were on the front page of the newspaper, so now the birth father knows where we are. He has already called me and threatened to kidnap his son because obviously I could not take care of him. Now imagine yourself as that parent. You can't even roll over in bed by yourself. But someone has threatened to kidnap your son and take him out of your nursing home, away from you. Yes, I had the restraining order. But can you, in good conscience, go to physical therapy for an hour and leave your room if you cannot be guaranteed that your child will be there safely when you return? Despite what might seem obvious, my physical rehab was not my number one priority. My son's safety was. Is that in my care plan? I still don't know. I haven't even seen it. But what might seem obvious to be in a care plan may not be what's most important to the resident. Have you talked with the resident? But furthermore, all of us probably have private issues within our lives, things that are rather personal that you would rather not share. But as staff members, we have almost a sense of entitlement in asking some very penetrating questions and expecting answers. Why should I bare my soul to a stranger who's charting it and I have no idea who's going to read this? People have a need for privacy, but yet, do you really know what is most important to your residents? It may not be what seems obvious. Imagine for a moment that we have this care plan in place. And I'm going back to this whole non-compliance issue. We have a care plan in place, and we've documented week after week the residents non-compliant, non-compliant, non-compliant. Now imagine for a moment that I'm a state surveyor coming in to review that chart. First, perish the thought. But if I were a state surveyor and I came in knowing nothing else, but I'm reviewing this chart that says this is the care plan and the resident is repeatedly being non-compliant, what that would signify to me is, perhaps this is a resident who is not allowed to participate in the development of his own care plan. Maybe I should look into a resident rights citation. Because if the care plan truly is resident-centered, resident-driven, resident-directed, if it truly represents the wishes of the resident, how can I be non-compliant with my own wishes? Allow that to sink in for a moment. Is that my care plan or someone else's? And if it is my care plan that I have participated in and helped to develop, where I have instructed you how to take care of me, then can I be non-compliant with my own wishes? And furthermore, if there is non-compliance, then who's being non-compliant with whom? Let that sink in for a moment as well. Have you seen the I care plans? They've been popular for a few years. A lot of places use those now. The care plan that is written in first-person language. So instead of the document saying, Mr. Jones is an 83-year-old man with a broken hip, it'll start out, I'm Mr. Jones. I'm 83 years old and I recently broke my hip. These are the things that are important to me. This is my personal history. It really contains all the same information, but it comes from a much different angle. Even though it is probably still an employee, a nurse manager, dietitian, social worker, who is actually writing it, it still forces you to look at the care plan from a much different perspective. I've talked with nurses who have done this, and including in my own organization, because I instructed them first to try this as an experiment. A new resident coming in, yes, I know you're writing the same care plan twice and we don't have time to waste. However, do this as an exercise. Write the care plan as you normally would, but then rewrite it in the first person. It was very enlightening, very much eye-opening. When you have the care plan, the final version of the document, who signs the care plan? Again, probably it's a nurse manager, maybe the social worker, dietitian, whomever. Does the resident sign his own care plan? I haven't found anywhere yet where that's the case, but I wonder why not. Because the care plan, in a sense, represents a contract. If it is resident-centered, resident-driven, resident-directed, then this is how I want you to take care of me, then why are you signing it and I'm not? It is a contract of sorts, and truly should be signed by everybody who has a stake in it, including the resident. So I want to go through an example of a care plan for a resident, and not so unusual, but perhaps we're admitting the 400-pound diabetic with pressure ulcers. It's not all that unusual these days. So the textbook care plan for someone in that condition would be 1,200 calorie diet, you need to cut out sugars and carbs, give protein supplements, and probably some diabetic training, some teaching. Is that kind of a general overview? I know there'd be some more specifics to it. Is there anybody here who would volunteer to go into that care plan? No, that is not a popular care plan. It may be necessary clinically, but it's not a popular care plan. Nobody wants that. Why are we writing a care plan knowing very well as we write it that there's no chance at all that anybody's going to follow it? Why are we wasting our times? Because we all know exactly what's going to happen. You're going to write out this perfect care plan, and we're going to be documenting non-compliant, non-compliant, because after you go home at 7 o'clock tonight, Their family's going to come in with the potato chips, the Twinkies, Ho-Hos, the Mountain Dew, whatever, because tomorrow your housekeepers are going to tell you what wrappers they found in the trash. Or in a case that I had, they're going to call the local pizza delivery place and tell them, come to the third window from the left of the main entrance. That's where I'm going to be. True story. When you think you've heard it all. So in essence, we've set up this perfect care plan, knowing very well nobody's going to follow it. And now we have everybody sneaking around behind each other's backs. And we wonder why we're not making progress. Why are we wasting our time? And we're setting up an adversarial relationship in the process. So this is what I propose as an alternative to the scenario I just gave. First, people are so scared of state surveyors, thinking my care plan must be picture perfect or else the state is going to zap me. No. And follow me for a moment. First, do your assessment. That must be on target. Make sure you cover all of your bases and have a very thorough, complete assessment. But then, and I know this takes a little more documentation, and we don't like that, but then I think we write out, based on my assessment, this is my recommendation. We're not jumping to the care plan yet. We're making a recommendation. That should be, probably, the ideal care plan that we talked about earlier. But then you document, these are the residents' wishes. Then you can talk about the Twinkies, the Ho-Hos, and potato chips and all that. You can say we've discussed the risks and benefits, and therefore we have negotiated this compromise which will serve as the care plan. It's not perfect, but it's somewhere in between. And perhaps rather than reviewing the care plan every 3 months, you need to review it every week or 2. Yes, that takes a little more attention. But I think a lot of us are probably doing this anyway. We're just not documenting as such. But this is a care plan, a product that probably we can live with and the resident can live with. And if we both sign it, it's a little more binding. So what have we done in this process? Well, first we've shown clinical competence because yes, your assessment was right on target. We've also shown that we're honoring resident preferences because we have stated outright, this is what the resident wants. We've discussed the risks and benefits. We've reached a compromise. We actually are making progress towards something. And maybe as we continue to revisit the care plan, the resident will realize, okay, the way I want to do it means my pressure ulcer is going to heal in 3 months. Your way might have done it in 1 month. Maybe now I'm starting to get a little antsy and ready to go home. So maybe we can become a little more aggressive. And we need to update that care plan. But it also has this partnership so we're not sneaking behind each other's backs, and perhaps may even impact your resident satisfaction scores, which now is starting to be calculated into payment. So the question I want to leave you with, whose care plan is it anyway? Thank you very much.